Also, we have many types of exercise and even other types of treatment beyond exercise that have been combined with exercise. So it's difficult to draw conclusions about the most effective exercise. So to kind of give you the thought process, the rationale for the exercise protocol used in this study, we use the assumption that poor alignment and stiffness contribute to the progression of thoracic hyperkyphosis. And therefore, those issues should be the target of an intervention. This exercise program focused on unilateral and bilateral movement, particularly of the upper extremities in diagonal patterns. And by using the upper limbs, that promoted more upright thoracic posture and mobility of the rib cage. So again, I mentioned that we were trying to get to a more clinically replicable time and chose 8 weeks. And only one other former study was known to address this time frame, and it was by Dr. Zhang, and it was shown to be effective. So the aim of this study was to examine the effectiveness of an 8-week corrective exercise program for thoracic hyperkyphosis on posture, balance, and well-being in older women with hyperkyphosis. So the participants, there were 50 women that consented. They were 65 years of age or older. They were recruited from 2 senior welfare centers in Daejeon City, and they were assigned to either the experimental group or the control group based on their location. So everybody in one senior center was the experimental group, and the control group was then age and sex, age and thoracic curve matched. So the inclusion criteria, they had to have a kyphotic angle of greater than 40 degrees using the dual inclinometer method. They needed to be able to walk independently without an assistive device. They were determined to have no cognitive impairment by getting a score of greater than 24 points on the Mini-Mental exam. And this is more of an exclusion, that they couldn't have any orthopedic, cardiopulmonary, or neurologic disorders that would impede their ability to participate in the exercise program. So it was a double-blind, group-matched study. So the assessors that took the measurements were blinded to what the group was doing for their intervention, and the participants were blinded to any other intervention. So they only knew that the exercise program as they knew it. They didn't know another group was doing anything different. So the measurements we took were several for posture. And keep in mind, this was Dr. Zhang's PhD dissertation. So you're always encouraged to use lots of measures and measures that have evidence of being reliable and valid. So that's exactly what she chose. So, she did the dual inclinometers for the angle of kyphosis, and then the kyphotic index, which is taken with the flexicurve, and the flexicurve is molded to the spine and then removed from the spine and put on a piece of paper, traced, and that is where you get these calculations from. So you can measure the thoracic length and the thoracic width of that curve. And if you are more interested in learning about the flexicurve, the geriatric section has a whole DVD to train you on this method. And then she also used the thoracic stiffness index. So for that, the patients were asked to stand at the best posture and then at their most relaxed posture. And then the KI was taken for both of those postures and divided, and less than 1 was considered stiff. And we've got people that are not muted again. I think it's Song. Could you please mute? Let's see. Okay, another posture was the craniovertebral angle, and this was done by a photographic measure. They had a light placed on the C7, and then the measurement was taken to the ear and then to a horizontal line to get the craniovertebral angle. And then tragus wall was also measured. And yes, this was not the participant, but we slipped his picture in there. And then the SPPB has kind of three components to it. The chair stands, the time balance test, and the 4-minute timed walk. And also limits of stability was done with a force plate. Well-being was assessed by the geriatric depression scale, short form. There is a Korean version, and with the SF-36. So intervention, this is kind of an overview of what the experimental group got. And we're going to break these four, down these 4 corrective exercises. So correction of the breathing pattern. They learned the diaphragmatic breathing, placing one hand on the belly and one hand on the chest and trying to emphasize the belly breathing. They started these in the supine position. And for the first week or 2 weeks, Dr. Jang was the therapist leading the exercise group. And according to her clinical judgment, she determined when she thought they had the belly breathing down and could advance to a more upright position. And then they went to sitting. Again, performed this exercise in sitting. And as they improved with that, went to a standing position where they're going to have to functionally use this breathing pattern in standing and moving about. Kind of the same thing for the thoracic mobilization. They started off in the supine position and prone position, working on mobility and flexibility and trying to stretch the anterior chest. So it was kind of a modified lower trunk rotation. The legs were crossed, the arms behind the head, and letting the knees fall side to side. And then the prone position to try and decrease the hyperkyphosis. As those improved, they went on and also did scapular retraction, again trying to open up the chest, and then in standing doing alternating arm raises overhead. They also did some stabilization or strengthening and started in supine and unilateral movements, then went to bilateral movements. They also did the active trunk extension in prone. And then as these got improved in their technique, then they added the sitting and eventually the same patterns in standing. Lastly, they did an awareness exercise, and for finding that good alignment, Dr. Jang made sure they were scooted to the front of their chair, feet reached the floor, so they were well grounded. And then they were asked to keep tall was the cue they were given. And they were also asked to try and use some mental imagery to think about a rope being pulled out of the top of their head and pulling them straight. And they did this eyes open and eyes closed. The intervention group for the control group was the same exercise program, but they only were trained in this as a supervised exercise program once. And then they went on their own. So they did it as a home program. They did have a booklet with the written instructions as well. And they were instructed to perform the exercises twice a week for an 8-week period, again, for a total of 16 sessions. The results, 22 participants completed the study for both the experimental group and the control group. At baseline, there were no significant differences between the groups in any of the measures. And I'm going to kind of simplify this. We did a 2x3 repeated measures ANOVA, and that kind of just gives you a big picture look at over time were there changes. And yes, there were statistically significant changes over time for both groups. And then you break that down with post hoc tests. So the experimental group showed significant improvements at the post-intervention, so at the 8 weeks, and at follow-up, which is additional 8 weeks later. They showed those improvements over baseline, except for the limits of stability test. The control group only showed significant improvement in the thoracic kyphosis, tragus to wall, and the stiffness index. We also did the percent change, and that's kind of a nice clinical-based measure of change, and the experimental group exhibited significant greater improvements over the control group at the post-intervention, except for, again, for that limits of stability and SF36, and at the follow-up 8 weeks later, except for the limits of stability. So the experimental group was better than the control group. There were a few of the measures that had MDC, and actually the angle of thoracic kyphosis had not had a MDC measured or calculated for it, and the calculation was done in this study. And it was calculated at 2.51 degrees, and the actual current study change was 2.2 degrees. So approximating that MDC, but not quite there. The SPPB has several different MDCs and MCID according to the population that it is being used with. So older adult African Americans, they determined it at 2.9 points for an MDC. Just older adults, 1.66, and sedentary older adults for an MCID was 0.3 to 0.8. The current study was at 1.4, so greater than the MCID, but not quite meeting the MDC. And the SF36, the MDC is 5 points, and the current study was 4.5 points. So again, very close, but not quite there. So our results show, even within this relatively short training period of 8 weeks, that corrective thoracic exercise appears to have a beneficial effect on posture, balance, and well-being. And that a targeted thoracic corrective exercise program, including the correction of breathing pattern, the thoracic mobilization, stabilization, and awareness of alignment, is recommended to enhance posture and function in older women with thoracic hyperkyphosis. And I put our contact information here at the end. This is one of the participants before and after. Nah, I'm just joking. But this lady is actually a famous bodybuilder from South Korea, and in this picture, she was reported to be 74 years old. I thought that was pretty incredible. Okay, and we'll pass it over to our case study.
So I want to apologize to all of you for the problems with the sound before. Having flickering power here, and I think it just keeps resetting itself. Our next participant is Dr. Sherry Betts, who is a longtime member of the Bone Health SIG, and she's written a phenomenal case report, and the full thing she's generously offered to share with us in jury notes. So that, make sure you read that. That's a real treat. Sherry? Oh, I bet.
Yeah, it's it got changed to inability to unmute yourself when we were having trouble with that. So, all right.
There you go.
Okay, are we ready, Michelle? Okay, so I want to talk to you about a case that I was inspired to use some of the exercises in Dr. Jang and Dr. Hughes's paper. And just want to introduce you to this lovely lady that I got the opportunity to work with. She is a 76-year-old female who came to me for low back pain after a kyphoplasty. So she had had mid-back pain that was sort of unexplained and unusual, and she sought out treatment for that and eventually went to get a kyphoplasty. And she is a bookkeeper. She likes to meditate. She does yoga and wanted to continue doing that. And then her other exercise history is that she loves to walk, and she's not a big, she likes to do classes, on-site classes, and she doesn't really like to exercise on her own other than to ride a stationary bike. So she rides a stationary bike, she said, every day since her children were young, and she rides the same stationary bike that she's had for about 30 years. So I thought that was kind of funny. She's got this sort of antique bike that she loves. And I tried to get her to choose a different form of exercise because of her bone health and because of the sitting and the cycling. And she already sits as a bookkeeper, so I don't really like to have her doing sitting activities. I want to mention a little bit about the process of treating her, because her low back pain was so debilitating that that was the main thing that she needed help with. The kyphoplasty was uncomfortable, but the area around that vertebral body that was repaired was not her main problem. She was definitely still kyphotic and presented with a pelvic girdle torsion. She had sacral malalignment, and almost manifested as a leg length discrepancy if you were just not super experienced in looking at that. And she also had very collapsed posture, and it was just something like really hips shifted forward, pelvic shifted forward, more of a sway back, and then very kyphotic lordotic posture where she was collapsing downward. And she had a nerve-root impingement on the left, which was causing a lot of left radiating pain. It also showed up in her reflex testing, where she was diminished on that left S1. She also had a bladder incontinence issue where she was a little bit leaky in the bladder, but nothing significant. She was able to control it if she coughed or sneezed, but she would have a slight amount of leakage occasionally with that. She always wore a pad, and I don't know if I want to share this, but it's kind of a really weird finding that I didn't actually put in the paper, but Michelle can tell me if she wants me to put it in there. But she said she started to notice that when her pelvis was really kind of rotated, that she would see a crease in the pad that she wore in her underwear. And she would also notice more leakage. at that time. So once we got the pelvis fixed and we, did manual therapy techniques, muscle energy techniques, taught the patient how to do it, she got much better, and we really were able to decompress that left L5S1 segment. And she was taught some lengthening exercises, some hanging from, I have a trapeze table, Pilates equipment. So she was hanging from the bar, and then we got her to get a one of those easily attached chin-up bars that you can just put up on the frame of her home. I gave her one of those that I had from years ago laying around, and she took that home and was using it to decompress that left side and really reach out. That was really pain relieving to her. So within a few weeks, she started to really do better with the incontinence and the back pain. And then we could really, and I actually started implementing treatment on the kyphotic issue, really inspired by the work of Wendy Katzman and Ivan Boutmans, who did manual therapy techniques for the kyphotic curvature, and Carlene Lindsay is one of my mentors in that arena as well, using some of those techniques to work on the thoracic kyphosis. Then we complemented that with exercise, doing some a little bit more passive treatment over what we call the baby arc or the ladder barrel in Pilates. And then at home, she would use either rolled up towels, a foam roller, or a ball. And then we incorporated the diagonal work in supine, as mentioned by Dr. Jang and in their paper, doing the TheraBand diagonals. Love the against the wall work. I didn't really do the sitting work with her because she already sits as an accountant. She already sits to ride that bicycle. So I really wanted to get her in standing more. And so I just did all of the exercises against the wall for awareness and alignment. And one of the things I wanted to mention about her too, that I did mention at the beginning of the case report that I wrote up, was that she was already a really good diaphragmatic breather. So what I felt was when she was standing and breathing, she was very collapsed, and then the diaphragm was really pushing the abdominal contents forward. So I chose to focus a little bit more on getting her rib cage up and lengthened, and did a lot more of the costal breathing with her. Because she was so good at the diaphragmatic breathing already, I started to try to get the rib cage moving a little bit more by practicing some costal breathing with a strap around her ribs. And that seemed to help her with mobility. It also helped her with the pain in the around the kyphoplasty area. So that being said, someone asked about plantar flexion exercises, standing heel raises. She did have some issues with balance, and 4-stage balance test. She was unable to really stand on one leg or the other at first. She actually still has trouble with that now, but we're really working with that to try to get her better at single leg stance. Heel raises were very difficult for her at first, so I had to put her right foot up on a stool while she did the left heel raise. And then that's gotten a lot stronger now. She can do those heel raises using either a finger touch or dowel for strengthening. And then we're still working on a little bit better dynamic balance with her. All of her functional tests improved after the intervention, and within about 8 weeks. And one of the things too that I wanted to mention was that because she has the compression fracture with the kyphoplasty treatment, that's going to make the vertebrae above and below a lot more at risk for fracture. So I'm very, very vigilant with her about the alignment and the awareness exercises. I loved that Dr. Jang and Dr. Hughes were mentioning that they included in their study. And we did the dowel alignment, so that we take the wall, I always call it a portable wall, and really getting her to focus on being able to pick up her cat litter bag and feed her cats. And she has a lot of cats, so she's a rescue lady, and she's rescued a bunch of animals. And when she would bend over to pick up the cat litter, and she felt like that was straining her back more than almost anything. And so we practiced every session with doing that because she almost could never stop doing the flex from her thorax. She continuously did that for weeks. And we kept practicing until I just basically had to drill it into her. And what I loved about Jang's paper was that they wanted to focus on awareness and not just doing the exercises, because so often I find that patients do really well with their exercise program and they make gains, they do well on their assessment and they make progress, but then they walk out the door and they're back to here again. And I feel that we really as PTs have to practice postural activities with people along with the strengthening exercises, the balance, the dynamic stability exercises, and really get them in their head that this has to be a way of life and they have to really embody that posture and that alignment all the time. And they have to be a little bit vigilant at first so that they become eventually unconsciously competent, because we're really trying to get them consciously competent. But our goal is to have somebody be able to go over here and pick up something off the floor and not have to really think about it. So I think I'll end there and turn it back over to the hosts. So thank you, Dr. Jang and Dr. Hughes for such a great paper. I'm really happy that research like that is being done. So thank you.
So you all should be able to unmute yourselves now if you want to address either any of the participants.
Hi, it's Leslie jumping back in. So I would like to thank Lynn and Dr. Zhang and Sherry Betts for this presentation. I'll start off asking a couple questions that have already been typed in. If you're an audience participant, please feel free to go to the chat box, which should be on your toolbar, and click the chat box icon, and that will allow you to type your question into the chat box. Make sure your question is addressed to everyone, and then we'll all be able to see your question in the chat box. All right, so the first, there are two questions that are related, and these two questions are primarily for for Dr. Hughes and Dr. Zhang. So question number one is, why did the control group, why did you decide to have the control group do the same exercises as the exercise group? And the second question that's related to that is, did you measure adherence to the exercises in the exercise and control group? How much different was the dose of exercise between the exercise and the control group?
So Dr. Jang, correct me if I'm wrong on any of this. So as I understand it, the South Korean IRB is just a little bit different than US and frowned upon the idea of no treatment at all. The two groups did not know that the other group existed, which I thought was kind of interesting. Everybody at that center was doing the same exercise program. The adherence was not measured, and that would have been nice to know, but the group that was the experimental group, Dr. Jang was in attendance and could see who was there, and they had to be there so many of the visits. Is that correct, Dr. Jang? But the control group, there was no record of their adherence to the program.
Yes, that's correct. And only dosage part of this difference between control group and experimental group was, that all exercise program was progressive exercises, which is we changed the posture and position, but that was in control group was they are self determined how if they want to they need to change their posture, but other dosage intensity and then dosage of exercises is the same between control group and experimental group.
I think the genesis for those two questions was, as you referred to, Dr. Hughes, that in the US, often a control group would do either no exercise or would do some completely different thing, like like they'd have an education session about kyphosis or something. So it was interesting that both groups got better, but the exercise group got significantly better than the control group.
Allison, may I make a comment about that? Because
Sure, of course. That's why you're here.
Good.
Yeah.
I don't want to steal their thunder. I thought that was great that they did the intervention exactly the same to see how they do on their own at home compared to what are we beneficial or not? Do we need to just give them a handout and say, go home and do your exercises? Or are we actually making contributions that are much more beneficial to the experimental group? So I thought that really increased the value of a teacher and someone giving you feedback. I thought that was such an important outcome of the study. So
yeah,
thank
you for that comment. Several of us in the APTA geriatrics are preparing a response to a recent huge article published in the New England Journal of Medicine about fall prevention program and how it's no different than usual care. But when you read what their intervention was, it was recommendations and referrals. They didn't actually do the exercises with anybody. They just told people to do exercises or go find studies where the exercises actually provided and supervision and feedback during the exercise are provided. That's where you see when you have only a short time frame, that's where you see the bang for the buck. All right, let me go on to another question. What was the mean range of the ATK angle? I'm not sure whether this questioner means before or after the intervention, or whether they mean the mean difference. I'm not clear from this participant.
So at baseline, in order to do the group matched, they were within 5 degrees and within 5 years of the person in the experimental group. So if the person in the experimental group was 70, then their control group person was between 65 and 75, and their angle of kyphosis had to be within 5 degrees of what that person had too.
Right, is that in the article?
Yes.
Yeah, okay. So to that questioner, if you want the exact angles, that data is provided in the article, and there's a link to that article at the top of the chat box and also in the invitation to this journal club.
Yep.
All right, the fourth question is my own. How might feedback of thoracic position contribute to improved motor learning in this short 8-week time frame?
Yeah, I think feedback is real important for the exercise and for educating on alignment. I guess I personally think about it more with the exercise because I see exercises done wrong so often. And if you don't give them the feedback and don't give them the cues, then they may not be using the right muscles or using them in the correct order and not getting the coordination out of that movement they should. So yeah, the fact that it was therapist led, I think is very important, that Joy was there, that she was an experienced PT doing the leading of that group, and that the group was a reasonable size too, that it wasn't so huge that she couldn't observe what we're doing with the feedback.
Just go ahead.
Can I add some comment? First of all,
Absolutely.
I really appreciate having this opportunity, because this study we've done is 2014 actually, and then I think it's this moment for as author is one of the great moments, like clinician applying this kind of idea and then how they exciting, and then they also their patient make them different. Like I think this is one of the great moments, like this all discussion event. Thank you so much, like to make this happen. So yes, your question. So I also really fascinating because we just our intervention only focus on thoracic structure, and even though stability, mobility exercise involved, but we was really focused on like we didn't do any kind of gait training and balance training or proprioceptive training. We didn't add that kind of that exercise in the program. But our outcome when we measure SPPB, which is included like the balance test and then gait speed test and also chair stand like test, that was also pretty improved after the intervention. So that point for me, like yes, very fascinating. Like how just like we didn't any specific like coordination, motor learning exercise involved in that program, but they were, I think, pretty. Their functional performance skill and physical performance skill is improved after the 8 weeks intervention.
That's great. I think the next question is, did you consider, oh, sorry, so let me scroll up. Sherry, did you consider some education for this patient on her sitting posture at work and while on the exercise bike? Do you also ask about sleeping positions? I would also think leg strengthening is especially important.
Yes. I had to abbreviate the case. I think I sent you 6 pages to start with, and they were like, "Oh, it has to be a lot shorter." I'm like, "Okay." So, leg strengthening. We did squats. With the dowel on the back, right, for the thoracic positioning to establish that motor control memory. And like I said, I had to drill her every session because even at the last session when I was testing her, she's still flexing in the thoracic without my reminders. And, so she really had to focus and work on that. And so yeah, leg strengthening, squats, lunges against the door frame at first, and then progressing to in the middle of the room. And I actually have a wonderful video of her doing that. So I need to she has a mask on anyway, I think. So in the video, because it was after COVID that we filmed these. Squats, lunges, heel raises, essential in her program. We did that the whole time. But what I also wanted to point out about improving thoracic kyphosis is that always improves balance. Always, I don't say always, but most of the time that improves balance. So once you improve thoracic kyphosis, getting the head over the body, their balance mechanisms are going to be much better, and their entire body responds better to perturbation. So I see that all the time. And the other thing, yes, definitely education on sitting posture. We talked about different surfaces, sitting on a ball, being a little more active in her sitting position. I actually had her sit with a ball behind her back, like an 8-inch small ball behind her back. And that really facilitated better posture. And if she slumped, the ball fell down. So I love that for reminder of posture for her in sitting. And like I said, I tried to get her off the bike. Even though I'd rather have her doing some movement, I don't want her doing that too much because we've seen that cycling can actually deplete bone density. So I'd much rather have her doing walking on her feet. And right now it's about 98 degrees at 8 o'clock at night here. And and the medical mall where people love to walk is closed. So it's been kind of troublesome for the gyms. People, are having a hard time trying to exercise in the heat. So they either have to get up at 5 o'clock in the morning or do it at 10 o'clock at night when it's 80 degrees instead of 90. So that, and definitely leg strengthening, definitely focus on sleeping position so they're not sleeping in a fetal position. getting the pillow bunched under the head, getting the shoulder out from under the pillow, and making sure they're not using too many pillows so their head is, you know, tilted upward. I'm a big fan of down pillows bunched up around the neck and without the shoulder being there if she's sleeping on her side. So that, I think I answered those things.
Great, thank you. The next question is, could you comment on the presence of shoulder pain, which I find to be common in my older female adults with kyphosis? Many of the exercises in the study involve TheraBand resistance to upper extremity overhead exercises. Do you find shoulder pain to be a common barrier, and how do you modify your interventions when shoulder pain is present? That's open to anybody.
Is that for me or for Dr. Hughes?
It says to everyone. I'll take anybody.
I'll go ahead and start, and then maybe they can chime in. So a lot of times I find the same thing, because especially when somebody's kyphotic, they lift their arms up. This is actually full shoulder flexion for a kyphotic patient. If you get better thoracic extension, usually the shoulder impingement gets better. So having them maybe put their hands behind their head, or put one hand behind their head if they've got a problematic shoulder, doing just one arm reaches or hand behind the head thoracic extension passively over a rounded object. And then eventually maybe taking the arms to maybe this position against the wall, and then pressing into extension here so that they're not in full shoulder flexion. And then also just doing against the wall work, where they're pressing the scapula and the thoracic spine against the wall, bringing the head to the wall. Those are great for improving thoracic mobility without lifting the arms overhead. In quadruped, that can be done as well, where they're just shifting back and forth in the quadruped position, or maybe even lifting out to the side instead of lifting straight up overhead into that impingement position. But again, working on that thoracic mobility with manual therapy, with passive techniques versus and progressing to active extension is going to probably help improve that shoulder function too, and pain.
Great. We're at 5 till 9, so we have time for another question or two. Does anyone else want to type in a question? Well, while everyone else is thinking about whether they would like to type in a question, I'll ask another question. So part of the reason I asked the question about feedback is there's this little device, I don't know if you've seen or on your blouse, and it gives you a little alarm if your posture is not extended. And I think, so this is just not me telling you what research to do, but I think you should do this research where you really have 4 groups. You have a control group with exercise and no feedback, a control group with exercise and feedback, your exercise group with no feedback, and your exercise group with feedback. And the feedback would not be for during their exercises. It would be, as Sherry mentioned, during their everyday life, when they're at their work desk, when they're picking up the cat litter, you know, those kind of things. And they get feedback about it's basically a trunk inclinometer. But it's advertised on TV, like, so that you can have a good interview for your next job. I know people are trying.
There's an app on your phone. I think it's called Lumo or something. There's a bunch of posture apps on your phone that you can actually download and put in your pocket too. But the phone is kind of big to walk around with.
Right. Yeah. This is like a little. It looks like a lapel pin. It looks like a lapel pin.
Yeah,
actually.
that would be good.
Yeah, and somebody is using that with people with Parkinson's disease, because they also have so much flexion, and people with Parkinson's disease are quite unaware of their flexed posture.
Right.
So I think that, so, you know, just if you don't have anything to do, Dr. Hughes and Dr. Zhang, I'm sure you have nothing to do and you really are flailing about for a new study. That's my idea. We have another question. Thank you, Cindy, for asking your question. Were you concerned that UC group? Oh, is that the control group?
Control problem.
Might be doing exercises improperly and possibly
uncontrolled group. Yeah.
having adverse events from that. That's for Dr.
Sorry, I didn't hear you. Can you repeat
She
again?
asked you, Dr. Jang, she's asking you, were you concerned that the uncontrolled group might be doing exercises improperly and possibly having adverse events from that? The ones that were doing the home exercises, were there any adverse events or fears about that?
Yes, I think it's a great question. So before that, like Dr. Hughes mentioned, in Korea, IRB is really strict. That's why we having that control group, but it's not like enough to change their, we expect to change their posture, but important thing is their safety is so important. So first session, what I did is really really detailed education for them, and then and a demonstration, and then we practice what kind of exercise you have to do, and then what and also the pain, always to follow the pain, and then any kind of the doing more, especially the mobility exercise training, and then we write down really clearly what should not do and then what should do. This is for all safety. They are elderly people, so I think thankfully, there is no any kind of the control group population was like any kind of injured or their problem, because I think they really understand well or follow that kind of a rule in the 8 weeks. So, but it's important thing you mentioned, Sherry mentioned, the education component is really important. Like, yes, and then also giving them template also really important. And then just we repeat the exercise, how they do well. And I know it's not enough, but yes, the one session education at the moment, I really really detailed educate them at the moment.
Mm-hmm. Allison, I'd like to add something that I think is important about this particular case, is that I recommended immediately that she go into a supervised fitness program because of the reminders I had to keep giving her. And what was great about it is that she was in her home environment. Her cats are running around. We're doing the Zoom class. I can see her. And she actually wanted me to be able to see her, because some people will hide from me and get in the dark or not have their camera showing. And she actually got into a place where I could see her and then watch her as she's doing her lifting, because we always do lifting every class. And then we do functional activities. And then we get on the mat and do some thoracic mobility work and strengthening. So with many of the exercises that are in this study that they're doing on a regular basis. So I try very hard to, as much as possible, shift patients into a community-based exercise setting where they're getting some motivation and some continued eyes on them for a longer period of time than just that 8 weeks of PT, because you know what happens. And guess what's happened? The last 3 weeks, she hasn't been in class. So I called her. I'm like, what are you doing? You're going to backslide. I'm like, where are you? And so she's like, I know my daughter's been in town. I gotta get back. I gotta get back. I'm like, you know what happens when you backslide? Because she's done it before. She was in my classes a long time ago. And then she kind of went by the wayside, stopped doing them, had the declines, had the fracture, got back pain, which returned, which is what I originally treated her for about 3 years ago. So so I had to call her up and find out what's going on with her. But I love that I can be involved in those community classes so that I can keep an eye on people, and then they can come back to PT quickly if they need something. And you can always ask a question right after.
Yes, and I think that's a great point. We're always trying to stress that when you're done with PT, you're not done. You need, there's the next thing that you need to do. So we are at 9 o'clock. So anyone that needs to leave, so I'd like to thank everyone for participating. If our speakers could stay on for a minute or two more, there are a couple more questions, if you wouldn't mind answering them. But to everyone else who wants to sign off, I'd like to thank you so much for joining us this evening, and give a silent round of applause to our, a muted round of applause to our presenters today. All right, so the last couple of, yes, right. Silent, like air hug, right? Like air applause, right? Okay, so so one question is, does anyone have or apps? If any of the clinicians have used it in their practice, thanks. So I think anybody who's on the call that wants to contribute could email your links about any devices or apps to jerrynoteseditor@gmail.com, and Michelle will get those. Is that okay, Michelle?
Absolutely.
Pardon?
Yes. In fact, I've used a couple clinically myself with a bunch of patients, so I'd love to chat with them.
Yeah. And please email your ideas to jerrynoteseditor@gmail.com. All right, the next question is, were patients with restrictive lung disease excluded from the study?
Dr. Jane, can you address that one?
So the question was excluded lung.
Yeah, did you exclude a restrictive lung disease?
Yes, we are excluded any kind of cardiopulmonary disease at the moment.
Mm-hmm.
Yes.
Okay, that's that was a clear question and a clear answer. All right.
I can see the next one, Allison.
Next question. Can anyone speak?
Go ahead, Lynn. Just take over.
Okay, so
Rather than
about addressing quality of life, I think on a bigger scale, like societally, through using personal trainers for in benefit of the public. And I actually have continued research and integrated manual therapy in with exercise. So Sherry, you and I have to talk later. I really am kind of a big advocate of get it to move and then use it. And I'm a PT. I have a bias. I think people ought to see PT first. And then certainly personal trainers or any kind of almost coach could do some of this work. But I think at first you have to kind of go to the root of what is keeping them from moving, because it can be joint, it can be soft tissue, it can just be motor learning and conditioning oneself to thinking about their posture, because it takes effort and it takes a consciousness about how you're positioning yourself. And the consciousness, yes, I think there are a lot of ways that you could get that feedback, like the apps and other devices. But that initial, you can't take somebody that's really stiff and just tell them to stand up straight and get them
right.
They've got to have that mobility before you can get the good posture. And I think that's what even PTs are guilty of a lot of times, is just telling people, oh, you know, this is how you need to stand. This is what you need to do. Well, it doesn't feel natural. I'm having to fight it. So I think we have to address those issues first. So I'm a big proponent of, yes, older people should not have to believe that their posture has to get worse. We ought to be promoting PT as a profession that you can go and help correct your posture. But I think it should be PT that addresses it first.
Can I comment?
Certainly.
So when I think about application of like clinical peer in this article, you know, this article is not, we not add Dr. Hughes mentioned manual therapy, which is, I also like manual therapist for a long time in South Korea. I love manual therapy and hands-on intervention for patient. But I also saw in this paper, we measured thoracic stiffness index, which is, yes, which was the population was the more 1 point, which is not, we just the defined less 1 point in kyphosis index was more stiffness. So the population in this study is not really stiff population. So I think that idea bring me so this kind of like the less stiffness population will be beneficial to more active intervention, especially exercise, like the focused intervention will be helpful. Just my assumption like that. But compare my previous practice, which is like I'm practicing in New York City, and thankfully I've been working with hypokyphosis woman in finally American. So they are so stiff compared to Korean. I'm really surprised. It's just my few cases, but I always check their kyphosis index. It's not like I measure specific flexic curve, but I just check like just relaxed posture and then straight posture. I see their movement, how they move and changing in specific thoracic spine. And if they are more movable, which is more like the more flexible, not stiff population, I do more at active intervention, which is yes, exercise and strengthening, and then the better outcome what I see. So that part I want to add more clinical peer for audience.
That's all of you contributing to this question and answer. This is, I think, really valuable because not everyone with kyphosis has the same presentation. Yes. And they might need a different approach or a different sequence of treatment. So that was great to get that question. I'm going to skip down to a question from Jeanette. Is there a certain point in a patient with kyphosis when correction is not possible any longer? Like, is there a point of no return?
Well, I would say when you start getting in there hands-on and doing some grade 4 modes and they don't move. Like once you, I mean, and then they have the same kyphosis index for several weeks, you know, obviously you're not going to make a change if you're doing aggressive manual therapy and then not seeing change, right? So at a certain point, you got to say, you know, you just got to do your best to stabilize the kyphosis, which Wendy Katzman's studies showed that her students actually stabilized their kyphosis, which is a great outcome to not get worse, right? So you just got to keep them strong and have them not get worse. They might need taping, they might need bracing, they might need some assistance as they get stronger, but at a certain point, you say, I'm not making change, so I'm just going to teach them some exercises to keep them here so they don't get worse, and maybe have them do periodic follow-ups every 6 months or so. So that would be how I would answer that.
Yeah, I totally agree. And then I think it's just a lot of component related how long sustained that kind of posture, more like maintenance. But I found these two components really important. The first one is my practical perspective, that spine trunk extensor strength level. I think that is maintenance there. The strength level is key point to their posture's maintenance. And then second one is the posture perception, training their posture perception. Is if the key maintain two components. In my practice, just my perspective like that. So they pretty like, I think this is more the beneficial. They can maintain their postures more longer, and I think this is I would say if they can keep going their posture, that's good way. But if they just maintain two components, I think this is going to be really beneficial for their maintenance, for their posture.
And I would say that nobody's too stiff to gain some. Returning to normal may not be possible,
Right.
but I think everybody can gain some. I've had people that just feel like a rock when you try and mobilize them, and I've found that they still get gains. Now I'm using usually a multimodal approach, so I'm using mobilization and exercise both, and posture training. So what of that is doing the trick, I can't say for certain, but I do think that we can make a change.
Well, that's wonderful. All right. So we still have some questions coming in, but it's 10 after 9. I do feel like we need to let our speakers and our audience go. I would like to thank very much Dr. Hughes and Dr. Zhang and Dr. Betts. This was awesome. I think a really well done study scientifically, but so clinically relevant. So many people that we see have this problem, and because they have this problem, they have other problems. And if we can treat this problem, then we see gains in these other areas, which you all mentioned. So really identifying where the problems are coming from, and if we treat that causative factor, how much else can get better. So this was terrific. I want to thank you so much for your participation, for your study, and for your case study. I'd like to thank everyone who participated in the call, either as a quiet listener or anyone who contributed questions or ideas. That was wonderful. And I'd like to thank the Journal Club team, which is myself and Michelle Stanley, the Jerry Notes editor, and Susan Patel, who's from APTA Geriatrics. And she will be taking over the Journal Club next year. She'll be flying solo pretty much. So we love having next Journal Club information just to let people know, and then we'll sign off.
Our next Journal Club is in September, and it will be presented by the Balance and Falls team, right?
Susan, you can jump in too, if you.
Yes, she's unmuted.
Can you hear me now?
Yes.
Yes, okay. I couldn't. Yes, so it'll be September 15th, Tuesday, from the Balance and Falls SIG. Yeah, correct.
Mm-hmm. Great. So have they chosen an article yet or not yet?
They have. The one,
okay.
the Enhanced Fitness Community Enhanced Fitness exercise program.
Wonderful. All right. So everybody who's participated, stay tuned. We'll be publicizing that shortly. Thanks, everybody, and good night. Stay safe.
Thank you.
Thanks, Sherry.
Thank you, Dr. Zhang and Dr. Hughes.
Thank you so much. Thanks so much for organizing.
Thank you. Mwah.
Yeah.
Thank you.